Madam, shall we start the session?
Yes, we shall.
Yeah. So thank you once again. Good evening, members. Today we will have the continuation of the previous session, that is about cervical cancer. In the previous class, we discussed about the benign conditions. So today, ma'am, we shall be will be continuing further. Once again, thank you, madam, for being with us. Dr. Anusha GK, who is assistant professor in Shivamogga Institute of Medical College, Shivamogga, and welcome all the students for this session. Over to you, madam.
Okay, thank you. So hope you all have revised the previous session that was on precancerous lesions of cervix. So just a recap of the. Just a second. Hello, can you all hear me?
Yes, ma'am.
Yes. Okay, so we'll quickly recap whatever we learned in the previous session in the next 5 minutes. So first thing is we learned the anatomy of the cervix, wherein it's a part of the lower side of the uterus, and it is lined by the columnar epithelium. The endocervix is lined by the columnar epithelium, and the ectocervix by the squamous epithelium, and the place where they meet is called the squamocolumnar junction, and that is where the transformation zone is. And in a reproductive age group, the transformation zone is well visible. It is about 0.1 to 1 centimeter of diameter around the external os. And this is the area where there is maximum metaplasia which is happening and is prone for HPV infection, which can result in carcinoma cervix. And then we also learned about downstaging of cervix, which is an experimental approach by the WHO, wherein these ANMs or the staff nurses can recognize by naked eye appearance, they can recognize the normal and the abnormal cervix and accordingly refer the cases to appropriate higher centers. And next thing is, so we all know what erosion is. So what is erosion or the ectopic? You can quickly type in. Can you all hear me? Yeah. So erosion or ectopy is, check. Okay. So erosion or ectopy is replacement of the squamous epithelium from the ectocervix by the columnar epithelium. It can happen during pregnancy or because of usage of OC pills and also because of infections. Now, ectropion is eversion of the cervical lip. And we all know about the cervical tear, which is usually asked as a short notes. And in this, it can be because of the delivery or because of various gynec procedures which we do wherein we hold the cervical lip and it can get torn. And depending on the bleeding, we can either use compression or we can ligate it with the hemostatic sutures. And then cervical hypertrophy, where the dimension of cervix is enlarged. Usually it is 3 by 2 by 1 centimeter. It can increase, especially noted in prolapse cases and also in carcinoma cervix, especially adenocarcinoma, which we'll be dealing with later. And the precancerous lesions of cervix. Here, these are the forerunners of carcinoma cervix. And so, and the precancerous lesions of cervix are classified based on the cytological smear into LSIL, which also means CIN1, where there is mild dysplasia, HSIL, which also means CIN2, CIN3, and carcinoma in situ, wherein there is moderate to severe dysplasia. Okay, last time there was a question wherein how can all these abnormal like CIN 1, 2, 3 can be detected on pap smear, wherein pap smear is just a surface biopsy. So the answer to this question is, see, if it is a normal cervix, then definitely when we take a pap smear, then it is only the superficial cells of the transformation zone which will come on the smear. Whereas if it is an abnormal cervix, that is precancerous lesion or cancerous lesion, what happens is the cells here they lose their structure, they lose their integrity, especially the cell to cell binding desmosomes are they lose their strength, and thus they remain very freely, they can be easily scraped when we do pap smear or any exfoliative cytology. So that's what is a basis of these exfoliative cytology, which is done in various cancers. It can be cancer lung or cancer of buccal cavity or anything. So basically, abnormal cells will easily detach from its base and come out. So depending on the depth of it, we classify it into CIN 1, 2, 3. We know it. If it is the basal 1/3, within 1/3 area is involved, it is 1, CIN 1. It is CIN 2 if more than 1/3 and less than 2/3 of involvement. And if whole thing is involved, then it is CIN 3. And I mean, if it is more than 2/3, then it is CIN3. If the whole thickness of the layer is involved, then it is carcinoma in situ. And further, if there is invasion into the stroma, it is the invasive carcinoma, in which the most common is squamous cell carcinoma. Is it clear? Yeah. Okay, next thing is, we all know the natural history of these precancerous lesions. They usually come or they arise in women at a very early age group, around 30 to 35 years. And LSIL, which is CIN1, about 1/4 of these cases can become carcinoma cervix. And HSIL, which is CIN2, 3, CIS, will take more than 50% of these cases can go into carcinoma cervix. So from this intraepithelial lesion to carcinoma cervix, it may take around 10 to 20 years. So there is a long pre-invasive state. Next thing is we also learned about various screening modalities. And then the management of pre-invasive lesion definitely depends upon so many things, so many factors, that is age of the patient, then what she wants, then the compliance of the patient. So based on this, we have conservative method where we observe with proper screening with pap smear, and we have local ablative procedures like cryotherapy, laser therapy, electrodiathermy, which is best mode in CIN1. And we have excisional methods like loop excision, electrosurgical excision procedure, and large loop excision of transformation zone. So this LLETZ is most applicable for CIN2. In cases of CIN3 and carcinoma in situ, hysterectomy is best. And next, yes, so carcinoma cervix is a preventable disease because of all these conditions. And we also have two vaccines available, which are Gardasil and Cervarix. And the vaccination can be started as early as 9 years, 9 to 12 years before puberty. And you can give this vaccine till the age of 45 years. And if she's already infected with HPV and there is precancerous lesion or CA cervix, then this vaccine is of no use. And there are 3 doses which need to be given. And first dose is the 0 is the first dose, then the second dose to be given after 1 month, and the third dose after 6 months. And the coverage of prevention of CA cervix is for about 7.5 years, is what the study says. And Gardasil is effective against 4 serotypes, that is 6, 11, 16, 18. Cervarix against 16 and 18. Now, we'll go into the carcinoma cervix. So, carcinoma cervix, the age of occurrence is usually bimodal. It is noted to peak around 35 years of age, and another peak is noted about 50 to 55 years of age. And we all know it is the most common genital carcinoma and is the second most common cause of death due to cancer in females. The first one being the breast cancer. Then what is the etiopathy behind the carcinoma cervix? We all know 99.7% of the cases it is because of the HPV, that is human papilloma virus, which exists in more than 120 serotypes, and the high risk group being 16 and 18 serotype. So this has a lot of affinity towards the metaplastic epithelium or the transformation zone. With good immune response, the infection can ward off, there can be regression on its own, and in certain cases where there are high risk factors, then the HPV infection can result in malignancy. So what are these risk factors? So one thing is the low socioeconomic status, which is associated with less of hygiene or lower education status, and then early age of coitus, early age of marriage, and then multiple sexual partners, high risk behavior in the women, and also men who are at risk, like those who have penile cancer or those whose first wife has been died because of CA cervix. So these men are high risk, and definitely the oral contraceptive pill usage, tobacco usage, smoking result in carcinoma cervix. And co-infection with HIV and other sexually transmitted diseases acts as a risk factor for carcinoma cervix. Next, so how do we screen? Again, we screen for CA cervix with all these methods which we dealt with in the previous class, and most commonly used method is a pap smear. And according to the guidelines, it is said that we need to reach out to at least 80% of the whole population in our country. And that's what lot of societies, the oncology societies, gynec oncology societies aim at. And in this pap smear, we all know how it's very important to advise the people, the women, regarding pap smear, and we need to be very sure about it. So when do we start pap smear in women? So can you just, yes, okay. So it is about 21 years. At 21 years, or once she's exposed to coitus, 3 years after the coitus, we can start doing the pap smear, and you need to keep repeating pap smear every 3 years till the age of 29 years. And again, after 29 years also, you have to keep doing every 3 years. But if in case you add on with HPV testing, HPV core testing, then you can screen with pap smear every 5 years. So every 5 years, pap smear along with HPV core testing. You can keep doing till the age of what? You need to do pap smear till the age of, till she reaches, yes, 65 years. Mekla, very good. So 65 years you need to keep doing. And in between she has undergone hysterectomy for any reason, say a benign reason, fibroid, then what you have to do, you can stop pap smear. Whereas if you have done hysterectomy for a precancerous lesion, then, or anything like carcinoma cervix in the early stage, then you need to keep doing pap smear. From the vault you need to take a smear, because there is high chance of vaginal intraepithelial neoplasia and vaginal carcinoma, which needs to be detected. So still you keep doing pap smear, and once two such pap smears which have done with a gap of 3 years have been negative, and only then you will stop pap smear. Okay, then, so what are the various types of carcinoma cervix? One is the squamous cell carcinoma, which is the most common type, accounts to 85 to 90% of carcinoma. Second one is the adenocarcinoma, and very rare kind of carcinomas are neuroendocrine tumors, the sarcomas, and the lymphomas. Next thing is, we'll go in detail about these. So squamous cell carcinoma, so it's the most common type, and usually you see it in older age patients, and the origin of the tumor is from the ectocervix. So you can see in this picture there is a mass at the transformation zone, or at around the os. So what are the types based on histology? We have large cell keratinizing type, large cell non-keratinizing type, and also we have small cell type of squamous cell carcinoma. So squamous cell carcinoma, the prognosis is much poorer because these are poorly differentiated cells. Next thing is the adenocarcinoma. This is seen in younger age group of women, around 30 to 35 years, and the origin is the endocervical canal. So what happens? The tumor keeps growing well within the cervix, so you can't detect it. See, if it is a squamous cell carcinoma, there is some growth which is evident at the os, whereas here it keeps growing internally. Only thing what you can see is the cervix is ballooned out, or it is hypertrophic. That's when you can think, oh, there is something here. And such carcinomas, adenocarcinoma, is known to grow very fast. And this adenocarcinoma is less radiosensitive, so you need to go in for surgery. And the various types of adenocarcinoma based on the histology are endocervical type, endometrioid type, clear cell, adenosquamous, and mixed type. Okay, now modes of spread of carcinoma cervix. So how does it spread? So first thing is a direct invasion, wherein it can invade the adjacent structures, and next thing is through the lymphatics. So we'll know more about the lymphatic supply of the cervix, and then is a hematogenous spread, which is mainly through the venous channels. And we note that the distant metastasis happens through the hematogenous spread, wherein it can reach out to the lungs, the bone, the brain, all this. And one more kind of spread, one more mode of spread is direct implantation. For example, say a carcinoma cervix lady delivers vaginally. So an episiotomy is given. So the cells get implanted into this episiotomy site or the cesarean section site. So there they can grow. So this is direct implantation. So this is one more mode of spread. Next thing, so this can be a short notes again, very very favored or favorite question of most of the gynecologists. So we all need to know the lymphatic drainage of the cervix. So cervix initially drains into the paracervical lymph nodes, then into the parametrial lymph nodes, which further drain into the internal and external iliac group of lymph nodes, further into the common iliac group, and then into the para-aortic group. And also you can find that the inguinal lymph nodes can also receive the lymphatics from here. So, during examination of a case, a suspected case of CS cervix, you need to look for lymph node enlargement, especially which are superficial, which can be made out like inguinal lymph nodes, then definitely the supraclavicular lymph nodes you need to look for. Next thing, so what are the symptoms of carcinoma cervix? So can you just type in quickly in the chat box? Okay, post-coital bleeding, very good. Vaginal discharge, then bleeding, yes. Yes, dyspareunia, okay. Intermenstrual bleeding, foul-smelling discharge, okay. Okay, pain abdomen, yes. So we'll just look into it. So these are all the symptoms of a patient which a patient presents with, and if she has CS cervix. What is it? So abnormal uterine bleeding, which can be in the form of menorrhagia or metrorrhagia, postmenopausal bleeding, or postcoital bleeding. Okay, so the common presentation is with respect to vaginal bleeding, and then they also can have abnormal vaginal discharge, which is excessive or which is foul smelling. And very rarely they can have severe pain, especially in the back, in the legs. It is noted that the uterosacral ligament involvement, the nervous bundle situated well within the uterosacral, so, and that is involved, and also the sacral plexus of nerves when they are involved because of CA cervix, then there is a lot of pain which is seen in the patient. And the leg swelling because of the lymphatic involvement, or because of what is noted, the ureteric obstruction, which is resulting in the kidney damage, can result in leg swelling, and the patient can have bowel and bladder disturbances depending on the involvement of these two structures. Okay, what are the signs of carcinoma cervix? So what do you elicit as a doctor on the patient with CS cervix? Okay, so there is a growth of vaginum. Yes, then okay. Ulceration, yes, bleeds on touch, very good. Okay, we'll see. So now, see, we need to not just look into the local examination of the vulva or all this. We need to look at the general physical examination also. So how will the patient be with CS cervix? She'll be emaciated, right? She'll be cachexic, and there'll be anemia depending on the amount of hemorrhage she has been having. And there is lymph node enlargement. We just discussed about the lymph nodes, right? Then on perspectrum examination, you may find that the cervix is totally normal, okay, or it can be infected. It can be infected, or there is ulcerative or irregular growth, and the mass is hard, friable, that is bleeds on touch, and it is fixed. And definitely we need to do a rectal examination, wherein you will look for the parametrium, wherein how is it, whether it is hard, indurated. Whenever it is indurated means what? There is inflammatory response which is being set in, and that feels hard. Okay, so any induration in the structures adjacent to the cervix. What is parametrium? It is a connective tissue around the cervix, right? So it can be the uterosacrals, the cardinal ligaments, and also the Denon-Villiers fascia, or anteriorly the pubo-vesico-cervical fascia. So all this together, all these things, the pelvic connective tissue is what is called parametrium. So also we need to examine it per rectally. Okay. The next thing, what are the complications of CA cervix? What you can notice. So one is hemorrhage. So we discussed that she can have abnormal uterine bleeding of various types. So there could be hemorrhage. And next is ureteric pain. So if, especially in case of third stage of carcinoma, where we'll study the staging later, so wherein there is involvement of the pelvic side walls and there is obstruction of the ureter, all this, then frequently she can go in for cystitis, pyelitis, and nephritis, and definitely there will be hydronephrosis, and she'll have frequent episodes of acute pain abdomen. And because the cervix is involved, the os can get closed and that it can result in pyometra. And also rectovaginal fistula, then vesicovaginal fistula can also result, which can be a result of the treatment procedures like radiotherapy which is given, or because of the infiltration of these tumor cells which is resulting in the fistula. Next thing is there could be relapse. That is, even after the primary treatment, there is recurrence of the disease. This is a complication, and there could be death. The patient can die, and usually the death is because of uremia, then hemorrhage, sepsis, metastasis, and gross cachexia. Next. Okay. So this slide shows how a slide should not be, right? It is too overcrowded. So this grossly gives us the staging of carcinoma cervix, which is mainly the FIGO staging, which was deduced in 1995. Okay, and how do we stage carcinoma cervix? It is a clinical staging. So clinical staging based on all these factors which you are noticing. That is, we examine the patient, we subject them to various investigations, and then we stage the carcinoma cervix. So what is it? We examine the lymph nodes, the vagina, then also definitely do the bimanual examination of the uterus, the cervix, and also the rectum. And this has to be done under anesthesia. So examination under anesthesia is important to stage the carcinoma cervix. Next is intravenous pyelography to know about the kidney, ureter, bladder, barium enema to know about the bowel status, chest X-ray to know the metastasis into the lungs, skeletal X-ray to know again the metastasis into the bones, and then various other procedures to confirm. Especially you can see here endocervical curettage. Have you heard about something called fractional curettage? See, it is just like the DNC, dilatation and curettage, which is done, which is diagnostic, whereas it is just like that, but it is done in two different fractions. So first fraction is always taken from the cervix, the endocervical canal, and then you take a specimen from the endometrial cavity. Even before you pass the uterine sound, you scrape the cervical cavity and then take the specimen. So in two different fractions we take the specimen. So that is fractional curettage. And we can also go in for cystoscopy, proctoscopy, and advanced investigations like CT scan, which is especially important to know the lymph node involvement. And lymphangiography also can be added. And MRI is known, or it helps to better delineate the metastasis or various soft tissue invasion can be better made out. And positron emission tomography is used to detect the relapse. Especially in relapse cases, we subject them to PTG. And so next thing, so we'll know more in depth about the various stages of carcinoma cervix. So we have 4 stages. So the first stage you can see here is wherein the tumorous growth is confined to the uterus. In this, we have stage 1A and 1B. 1 is wherein it is microscopically visible. You cannot see anything on grossly or naked eye appearance. You may not make out anything. And in this, we have type 1A1, wherein the depth of invasion is less than 3 millimeter, and stage 1A2, where the depth of invasion is more than 3 millimeter. Next thing is stage 1B, where it is clinically visible. You can see some lesion at the cervix. And here, depending on how big the lesion is, if it is 4 centimeter or less than 4 centimeter, it is stage 1B1. And if it is more than 4 centimeter, it is called stage 1B2. Next, this is stage 2, wherein the tumor grows well beyond the uterus, but it doesn't invade the pelvic wall or doesn't go into the lower part of the vagina. Wherein if these two happen, then it fits into stage 3. So it is just within the uterus. So we have stage 2A, where the parametrium, we just discussed what is parametrium. So in stage 2A, you will find that it is going into the vagina, but it is not going into the parametrium. Okay, and stage 2B is when the parametrium is involved. Next is stage 3. In this, what we see, it extends even to the lower vagina and also to the pelvic side wall, and also it can involve the ureter and affect the kidneys. In that is stage 3A is wherein the lower 1/3 of the vagina is involved, and stage 3B is when the lateral pelvic wall is involved. And so what happens in the lateral pelvic wall? You have the ureter. Because of the lateral pelvic wall involvement, there could be compression on the ureter, or there could be direct invasion into the ureter, which will affect the kidney, wherein there is hydronephrosis noted in the kidney. Okay. See, these whatever I'm quoting are all from the standard books. So that's what I can say about the various measurements, which can vary in different texts. And next thing is stage 4. Stage 4, wherein we have the tumor growing into other organs. 4A is wherein the mucosa of the bladder and the rectum are involved, and it extends beyond the true pelvis. And stage 4B is a distant metastasis, where it can go into the lungs, into the bones, into the brain. Okay. Now, so prognosis, we all know what prognosis is. Wherein we detect or we elucidate the survival rate or the cure rate of the patient, right? So what does the prognosis depend on? It depends on the extent of the growth. The initial staging is very, very important. So based on this, we have early and advanced, though it is not well defined by many of the standard books. It says that early stage is a stage 1, and anything 2 and above come under advanced stage. And the prognosis also depends upon the site. If it is endocervical, then definitely we know that it grows very fast and gets detected very late. And if the size of the lesion is very big, um, then definitely the lymphovascular space invasion is much more. And histopathologically, we discussed, we have poorly differentiated, moderately differentiated type of cells seen within the tumorous growth. And if it is poorly differentiated cells, and definitely the prognosis is poor. And if age wise, if it is seen in the younger age group, then the prognosis is said to be poor. And depending on the lymph node status, if in case during surgery we notice that certain lymph nodes are involved, and especially if it is para-aortic as well, then we know that we are handling a stage 4 kind of a disease, and we need not even go in for completing the surgery. We can abandon the surgery and we can proceed towards radiotherapy. And definitely also the status of the margin of the tissue, the tumor growth. Say I send in for a frozen section when I'm operating, and I notice that the margin of the cells are still positive for tumor, then again there is prognosis is quite bad. Okay, then how do we manage carcinoma cervix? See, one where we have preventive management, wherein we look into managing it at a primary level, primary prevention, that is we bring in awareness among women, we educate them about various risk factors for carcinoma cervix and ask them to refrain from getting into all these risk factors like smoking or tobacco or all these things, the risk factors which we discussed. And next is the vaccination, which we discussed, and definitely screening. Screening is a secondary prevention wherein we detect if there is any disease and accordingly we treat, we give the further treatment. Next thing is a curative method of carcinoma cervix treatment, where we have these four modalities: surgery, radiotherapy, okay, surgery, radiotherapy, chemotherapy, and palliative therapy. So again, so this slide shows that at different stages, what all steps we need to take or what are the modalities of treatment we have. So we'll discuss in detail again. Okay, in this you can see, if it is stage 1 carcinoma, then what to do? See, if it is stage 1A, then what do? In 1A, we have again 1A1 and 1A2, right? So in 1A1, where is less than 3 centimeter depth and less than 7 centimeter extent, okay? So without lymphovascular space invasion, so lymphatic involvement is not there. In such cases, what we can do? We can go in for conization or simple trachelectomy if she wants to conserve her uterus so that she can better plan her family. Okay, or if she says that okay, I would want to get I would want to get my uterus removed, then you can go in for type 1 hysterectomy. We'll know the various types of hysterectomy later. Next thing is, if this stage 1A 1 is with lymphovascular space invasion, then you can again go in for simple trachelectomy. Notice that here we are not doing conization. Okay, conization, yes, we'll deal with it in depth. So then in this case, with lymphovascular space invasion, we can go in for type 2 hysterectomy with pelvic lymph node lymphadenectomy, which is also called as Bernstein's hysterectomy. Next is, if it is stage 1A2, then we can go for radical trachelectomy, type 2 hysterectomy with pelvic lymphadenectomy. Next is stage 1B, where we are seeing a lesion through naked eyes. So what do we do if it is stage 1B, where it is less than 4 centimeter? Then we can go in for radical trachelectomy or type 3 hysterectomy, which is called Meeks hysterectomy with the pelvic lymphadenectomy. Okay. Then stage 1B2, here we can go for type 3 hysterectomy with pelvic and para-aortic lymphadenectomy, or we can go in for primary chemoradiation. So notice that we can go in for chemoradiation as early as stage 1B. Next thing, what do we do if it is stage 2? Stage 2, what is it? It is extending beyond the uterus. Yes, it involves the upper 2/3 of the vagina. Then it is called as stage 2A, where we can go in for type 3 hysterectomy. Yes. See, 1B. Sorry, what is the question? Okay, I'll come back to the questions later. Okay. I just wanted to confirm. Is there a next class scheduled at 6 o'clock?
Yes, ma'am. Actually, 6 o'clock.
Okay. So what's the time now? We have 20 more minutes.
It's 5:40, ma'am. We have 20 minutes, ma'am.
Sure. Okay.
Yes, ma'am.
That's why I'm a little fast today. Okay. So
Yes,
in stage, Yeah, in stage 2A, we can go in for type 3 hysterectomy with pelvic and para-aortic lymphadenectomy or primary chemoradiation. Stage 2B, where it is involving the parametrium, then you can go in for primary chemoradiation. Notice that here we are not doing surgery. We are directly doing and referring them for chemoradiation. Next is stage 3A, wherein the lower part of vagina is also involved, and stage 3B, where it is extending to the lateral pelvic wall, the ureter, and the kidney. Here again, primary chemoradiation. And stage 4A, here where the rectum and the bladder is involved, you can go in for chemoradiation or primary exenteration procedure. Stage 4B, you can go in for primary chemotherapy with or without radiation therapy. Okay, so what are the various surgeries which we do in carcinoma cervix? So these are the 4 things. We'll deal with them in depth. One is conisation. So here we opt for it when the patient wants to preserve her uterus. Yes, she wants to have or plan her pregnancies later, and it is done only for the case of stage 1A1, that too with no lymphovascular invasion. So once this is done, what can happen during the next when she becomes pregnant, when she's carrying, then she can have more of abortions, mid-trimester abortions. Cervical incompetence is very common. Next. So this is trachelectomy. So trachelectomy means what you can see in this picture. This part, the cervix is surgically excised, and the uterus is attached or sutured to the leftover vaginal part. Okay, so that is trachelectomy. We have simple and radical types. So simple is when only this procedure is done. Radical is when along with this procedure we remove or excise a part of the cardinal ligaments and the uterosacral ligaments depending on the involvement. Okay, if you have noticed for stage 1A1, that too with no stage 1A1 we go for simple trachelectomy. Radical trachelectomy, when there is an evident lesion and also lymphovascular space invasion, we go in for radical trachelectomy. Okay, so complications, again there is no cervix. So imagine a lady who has become pregnant with no cervix, which is the doorway for the uterus. So they can go in for abortions. Okay, next. So various types of hysterectomy which we discussed during staging management. So type 1 hysterectomy is a simple hysterectomy which we all might have noticed in our colleges. So that is total abdominal hysterectomy. Now when doing hysterectomy, if the cervix is left behind, it is called as subtotal hysterectomy, wherein stump carcinomas are very common. Okay, now next thing is the type 2, which is modified radical hysterectomy or Wertheim's hysterectomy. Now the specimen you are seeing here, this is after the Wertheim's hysterectomy. You can see that there is TH, the uterus, the cervix removed. Along with that, bilateral salpingo-oophorectomy is done. Along with that, the bit of the vagina is also taken out, and the broad ligament part is also taken out, and also there is pelvic lymph node dissection. So all this together is called as Wertheim's hysterectomy. Okay, now type 3 is also called Meiggs hysterectomy, wherein apart from Wertheim's hysterectomy, what is added is the length of one more thing in Wertheim's hysterectomy is the cardinal ligament and the McEnroth's ligament, McEnroth's and the uterosacral ligament. The medial 1/3 of it is scraped out or excised. In type 3, apart from the whole thing what we discussed in Wertheim's hysterectomy, what we do is we remove the whole of the cardinals and the uterosacral ligaments along with extensive pelvic node dissection. Okay, type 4 is when even the vagina part is excised. Type 5 is ultra radical hysterectomy, or also called as pelvic exenteration, wherein apart from all this what we discussed till now, what we do is wherein there is bladder and bowel involvement, so we go in for this pelvic exenteration, wherein the bladder is also excised and the ureter is attached to some part of the bowel. Okay, a pouch is formed in the ileum or in the sigmoid, and then that is called as anterior exenteration. Now if posterior exenteration is even the bubble involvement is seen. So the rectum is taken out or the sigmoid is taken out and a colostomy, a permanent colostomy is made. So that is, this whole together is called pelvic exenteration. Next thing is radiotherapy. So this is a treatment of choice for majority of the cases. We notice, yes, as early as stage 1B itself, we are starting with radiotherapy. And the principle here is various radiation sources, for example, like radium, cesium, cobalt, these are all used. And the gamma rays from these radioisotopes and certain cancericidal dose is fixed for particular tissue and for particular person. And this, and whenever the gamma rays are exposed, then the cells undergo death and fibrosis. And notice that because these tumor cells are more sensitive to these gamma rays, so they die faster. And even the surrounding normal cells can also get affected if a higher dose of radiation therapy is given. And definitely the effect of radiation therapy depends on the radiosensitivity of the tissues, and we noted that adenocarcinoma is less radiosensitive. And to make the cells more radiosensitive, we need to make sure that they are well nourished. That means that anemia needs to be corrected. The oxygen carrying capacity of each cell or delivered to each cell needs to be looked into. So we need to look into the nutritional status and also the anemia status before we start radiation therapy. What are the various techniques? We have external beam radiation therapy. We have intracavitatory radiation therapy. We also have interstitial. The last two types are the brachytherapy, where the source of radiation therapy is placed very close to the organ of impact. And what are the various complications? As stated, if the radiation dose is very high, then what can happen? Even the normal cells can die. So the all normal cells can get affected. So we need to be very cautious. Before we go into radiotherapy, we need to make sure that the vagina is the bladder is the vagina is well packed such that the bladder and the bowel are made to stay away. Or we when we are doing certain operations, say one early stage of stage 1, when we are operating, we can transplant the ovary into say into the gutter or anywhere, so that we expose the ovaries lesser to these radiations. Okay. Next thing you can see in this picture, these are the instruments used to give radiation therapy. These are called tandems or the applicators. Okay. And you can see here in this picture, this is a kind of intracavitatory radiation therapy where the tandem is placed within the vagina, and this is the X-ray radiograph of this. And here, very important thing in radiotherapy for carcinoma cervix is the point A and point B. You need to know about these 2 points. And how do we make out the point A? Now, from the external os, 2 centimeters above and 2 centimeters lateral from the external os is point A. Now, from the point A, if 3 centimeters lateral in the same plane is point B. These 2 points are important. Whenever I'm giving intracavitatory radiation therapy, what I do, I fix certain dose for point A and fix certain dose for point B. So this is usually asked question. Next coming to chemotherapy. So chemotherapy drugs used usually are cisplatin, bleomycin, ifosfamide, methotrexate. And what do these drugs do? These drugs make sure that they shrink the tumor cells, and thus it can be helpful pre-operatively as well. And in cases of advanced carcinoma, we just noted in advanced carcinomas, we can use chemotherapy for treating. So next thing is stump carcinoma, we just discussed. When we do a subtotal hysterectomy, that is, we leave behind the cervix, which is not usually advocated. Okay, especially subtotal hysterectomy is done if in case, especially in emergency hysterectomies or cesarean hysterectomies, or when there is a lot of additions in the lower segment, in the cervix area where dissection of bladder is not possible, then we end up just completing the subtotal hysterectomy. So what happens? We leave behind the cervix. So this cervix there can be tumor growth in the cervix, and this is called a stump carcinoma. And the incidence is 1%. And if well within 2 years of the primary surgery, if there is carcinoma noted in the cervix, then it is called true carcinoma. Well, after 2 years, okay. If it is within 2 years, then we should think that okay, there was, when we were operating, maybe it was a case of some precancerous lesion or a cancerous lesion which went missed out, and this fits into false stump carcinoma. Okay. Next is the management is, see here we need to go in for external beam radiation therapy, which is most preferred for stump carcinoma, because we can't go in for surgery because there'll be a lot of additions, and we can't go in for radiotherapy because the bladder and the rectum are just situated above the stump and they're very proximal to the radiation source and can get affected. So best would be external beam radiation therapy. Okay. So we had many questions in the last session about carcinoma cervix during pregnancy. So here we go. So the incidence is 1 in 25,000 of pregnant women. Okay, and what happens? It goes missed, or we do misdiagnosis of carcinoma cervix, because what happens is, if you see the morphology during pregnancy, you will find that there could be erosion, there could be ectropion during pregnancy. Okay, we even if we see abnormal cervix, we may think that, oh, this could be because of pregnancy. Okay, so as such the lesions can go missed. And even if there is bleeding, say coital bleed, post-coital bleeding, or any of these things, then during pregnancy, if we see bleeding, then we attribute it to pregnancy related conditions. Okay, it could be some implantation bleeding, it could be some threatened abortion, like this. Okay, so one thing is, whenever the patient complains of bleeding, a pregnant woman complains of bleeding, we need to examine the cervix very well. And definitely the WHO or ACOG, they all recommend that every pregnant woman should undergo pap smear at the first ANC visit. Okay, in case the pap smear is normal, very good. If the pap smear is abnormal, that is a positive result is obtained, then what we have to do, we have to reconfirm it with colposcopy directed biopsy, wherein we should be ready to face certain amount of bleeding. Okay, because of the progesterone effect, there is higher vascularity to the whole of the uterus, and she can bleed a lot. Okay, so we should be alarmed about it. And in case it is still not confirmed on colposcopy, because say colposcopy is negative, but there is a gross lesion which is there, then what I can do, I can go in for diagnostic conization. And if I have to go in for conization, the best time would be second trimester, because first trimester, more chance of abortions are noted. Okay, next, how do we treat? See, treatment during pregnancy totally depends upon the gestational age, and what is the desire of the patient, and also the stage of the disease. Now, if it comes as CIN1, the precancerous lesion in the woman, then what we do, again, we can just observe, we can do a conservative management. If in case it is CIN2, 3 or LSIL, HSIL, wherein 2, 3 or CIS, then again we can still observe by repeated pap smears, well, to looking at whether they are going into an advanced carcinomas. Okay, and also if in case it is stage 1A, okay, then what we have to do, with no lymphovascular lesion, okay, no lymphovascular lesion, then what we can deliver such a patient vaginally at term. We can take her till term, deliver her vaginally, and after this, about 6 weeks later, if she wants to conserve her uterus, you can go in for conization. If not, she has completed her family, then you can go in for hysterectomy. Okay, stage 1. Okay, stage 1A1 with lymphovascular space invasion, and stage 1A2 delivery at term. You can take her till term again, But here you need to go in and do cesarean section. You need to deliver her by cesarean section because implantation or excessive amount of bleeding is noted in these stages. Okay, more spread is noted in this stage. That's why we go in for cesarean section. And also later on, and also at the same sitting, say when I'm doing cesarean section, I have to do radical hysterectomy with lymph node dissection at the same time. Okay, but we need to be very careful because there could be a lot of bleeding. We know that gravid uterus receives a lot of blood supply. Say 750 to 800 ml of blood every minute is pushed into or pumped into the uterus, gravid uterus. So there could be heavy blood loss during hysterectomy when we are doing cesarean section. Okay. Next thing is stage 1B. So you can delay the delivery for you can prolong it for next 4 weeks. Okay. You can also check. You can also see if you can prolong it till at least the lung maturity of the fetus is obtained. That is, you can push it till 34 weeks and then you can deliver by cesarean section and also with radical hysterectomy and lymph node dissection. Next thing is, if in case you find anything stage 2 and above, you instead of going in for surgery, you can start with the radiotherapy as we discussed before, radiotherapy, and you need to explain the patient about the risks and complications of radiotherapy to her and definitely to the fetus. Yeah, thank you.
Thank you, ma'am. Hello, ma'am.
Yes.
Ma'am, thank you, ma'am. It was wonderful session. Sorry, ma'am, we have time constraint. Like, actually, I'm sorry, actually.
No, it's okay. Actually, I don't know how, because I was a little more faster today. If you have any queries, feel free to ask. Definitely, few questions will come up on the chat box, so I'll be
Yes,
replying
ma'am.
to.
We will. Yes, ma'am. We'll forward the questions to you, ma'am. We'll save the chat and we'll forward it to you, ma'am.
Yes. Okay. Thank you, everyone.
Thank you, ma'am. Thank you so much, ma'am.